Thank you. Hello, everyone. I'm glad to chair this webinar organized by the Euretina and Euretina. So this is a webinar on pathologic myopia. We will discuss two main subjects about this particular disease. The atrophic and neovascular complication of the disease. And we have two major specialists in this domain. Professor Jorge Ruiz Medrano from Madrid, Spain, and we will have in a few minutes Aude Couturier from the French Institute of Myopia in Paris. And then we will discuss about the surgical problems associated with high myopia. And we've got two other specialists. Matteo Carla from Italy is now working also in France in the French Institute of Myopia in Paris, but is from Rome originally. And we also have the Dr. Elise Philippakis from Paris too. And they are very good surgeon, and they have a lot of experience in operating high myops patients. So we will begin with some cases about atrophy and neovascular disease, and then we will switch on surgical problems. So we can begin our discussion, free discussion, and at the end of this hour of webinar, we will hopefully answer your questions. So we will present some cases with Professor Jorge Ruiz Medrano. So I know I talk maybe. So this is a woman. She came to me a few days ago, and she's 65 years old. She is followed up for degenerative myopia, and she was operated on for macular hole on the left eye. Her vision on the right eye is good, 8 on 10, and fair good on the left eye too, as you see here. So how can you describe the fundus? Hello, Aude.
So I think the most obvious finding, and maybe the most relevant to these cases, is a wide posterior staphyloma. And we can see that, especially in the left eye, you have some patches of atrophy, especially peripapillary patches and perivascular. And in these cases, it will be very interesting to take a look at the OCT that we have now.
Okay. I don't know how to, okay, I managed to pass the slide. So the OCT on the right eye is this name. Maybe you can speak about this particular pathology and tell us about what the link of this pathology with atrophy.
Okay, so this is a pathology described by your group, actually, which is dome-shaped macula. Then you can see how the profile of the central area of the macula is not flat or is not concave, but convex. It was first described that there's difference of 50 microns between the level of the RP subfoveally and at the bottom end of those two sides. And here we have the other eye with a very similar profile and some changes we will have to take a look at, like choroidal thickness and scleral thickness around the area of the dome and on the edges.
So as you can see here, the bulge is very important in the left eye. And do you think, does it make a difference with the atrophic pathology that we see, especially in the peripapillar area?
I think that's hard to say with what's been published up to date. We see that the patches of atrophy in the macula are not really centered, and the peripapillary atrophy is not that different to the other eye, despite the differences in the height of the dome itself. There's a bigger difference maybe in choroidal thickness under the dome when you compare this eye to the right one. Choroidal thickness here is pretty regular across the B scan, whereas here you can clearly see that dilation of vessels there in comparison to the rest of the choroidal profile.
Okay, I don't know if I can change the
I
slides. Maybe we can move on the.
Yeah.
Yeah, we can see different type of patches of atrophy. You can see here on the nasal vessel on the superior an atrophy around the nasal vessel, and then we can see the patchy atrophy around the optic nerve and some small patchy atrophies on the inferior part of the eye. Is it different? What do you think about that? And has it a meaning in the progression of the disease?
Well, to the questions we have in the slide, if the classification of the atrophy is important, we just discussed it. For everyday clinical practice, it may not be very important. It's important for studies or for trials, probably. But the one thing that is relevant is that the presence of patchy atrophy is usually what comes associated to a vision loss. So I know there's been some trend towards describing this perivascular myopic atrophy, which is always very interesting to report. But to the best of my knowledge, I haven't been aware of a relationship between that and visual acuity. So it's important for studies, and patchy atrophy comes with vision loss, and that's important for clinical practice. But more than that, I'm not sure about.
Okay, but I think it's really important. What do you think, Aude? I think that this particular grade of atrophy, the patchy atrophy, is a milestone in the life of myopic patients, because we know from your studies, both of your studies, that it is a great risk for vision in patients with patchy atrophy.
Yes, I fully agree with you, David. And now we have several studies showing that it's really a change in the life of highly myopic patients. There's a very good also a study from Matteo about a large number of eyes with a long follow-up, more than 10 years, show that the risk of progression is really also higher in patients with patchy atrophy. More recently as well, the role of the inflammation has been questioned, and a good also paper from the team of Professor Bandello and Dr. Cicinelli discuss the possible role of inflammation and the role of having some lesion that seems to be more peak lesion occurring secondary to lacquer cracks that can maybe leads to this kind of small, more small area of patchy atrophy. And we know that the rate of progression may be different depending on the origin of the patchy atrophy. When there is also a Neovessel occurring, the progression of the atrophy is quite fast. Maybe the inflammation also play a role with the faster growing, but it needs to be also confirmed by future longitudinal studies.
In that case, for instance, the small patchy atrophy that we see in inferior part of the eye, could it be some inflammatory lesions? We don't know, but I mean,
yeah, we don't know.
The type
I think
of patchy atrophy that you think it may be inflammatory.
It could be. OCT should be more informative to confirm. Of course, we don't always see the lesion at the active phase. If it's not in the fovea or close to the fovea, the patient may be asymptomatic, and we see only the lesion at the inactive phases. But the OCT showing this a very small area of atrophy with a collapse of the external retina and hypertransmission to the choroid may also lead to the suspicion of inactive peak lesion. and try to look for active lesion in the future in the follow-up of the patient.
Okay, maybe we'll come back to this discussion afterwards with your cases. So this is the third cases. This is a woman, 77 years old, and she's followed up also for myopia, and she's got a vision very low in the left eye. And as we can see here, there is no real patchy atrophy. Jorge, maybe you agree with me.
Yeah, completely. The only atrophy you can see in these fundus photographs are this diffuse choroidal atrophy, but not real choroidal patches. So no.
Maybe we can pass. Yes, and this is the autofluorescence. And what you can describe maybe the autofluorescence and tell me, is it really important to do autofluorescence in highly myopic eye? And maybe Aude, you can also answer this question.
Well, autofluorescence is the gold standard for the choroidal atrophy measurements and determinations. That's true. We can see some RP irregularities, but that's just diffuse atrophy. It's true that we can also see some perivascular deeper atrophy patches, but the macula itself only shows diffuse atrophy, which should not be associated to great loss of vision.
Can you confirm that, Aude? Because I think you made a study about autofluorescence and atrophy in highly myopic eyes. Is it really linked?
Yeah, well, in our team, Dr. Hugo Leboité and Dr. Paul Goupillou conduct a study mainly to assess the autofluorescence quantitatively in the early cases of atrophic maculopathy, so tessellated fundus and diffuse choroidal atrophy. Because in these early stages, the classification is based on color fundus photograph. It's not always easy, and the meaning of these different stages is not fully understood. So we decided to conduct this study to assess to quantify autofluorescence in early stages. And the results show that tessellated fundus had autofluorescence that was quite close to control, that were mild myopic eyes, while in diffuse choroidal atrophy, there was a significant reduction of the autofluorescence, probably because of this RPE dysfunction. It was also correlated with the thinning of the choroid, with a significant decrease in the subfoveal choroidal thickness. So probably the tessellated fundus with this normal autofluorescence is not so pathologic. That's also what we know from the natural history study, with less progression to the more advanced stages, while the stage of diffuse atrophy may be the first stage of real RP dysfunction and RP stretching due to the high myopia that can lead to further progression to other stages. So
okay. Maybe we can see the OCT. And Jorge, what do you think about OCT? And this is the right eye, and this is the left eye. So I put the thickness of the subfoveal choroid. And do you think it can explain the loss of vision? Well, Aude partially answered the question, but maybe you have another explanation for the loss of vision. We talked about it a few minutes ago.
Well, the choroidal thickness has been correlated to axial length and to the degree of myopia of the patient, but not to the visual acuity in the end. Taking a closer look at these OCTs, if we look at this eye, maybe the nerve fiber layer is not in great shape, and that could explain the vision loss partially, but it's true that the RPE doesn't look perfect either. So you have those RP alterations there together with a maybe an involvement of the nerve fiber layer that could both participate in that vision loss, but it's a hard question to answer.
Okay. Some publications said that 65 microns of the subfoveal thickness is the limit for considering choroidal atrophy. Do you agree with that?
Well, it's what's been published, but to set a threshold for that, I mean, you would need to have a correlation with visual acuity.
So you don't look at it in daily practice, not really.
Not really, no.
Okay.
It's clear these cases with those really thinned out choroids, you always get the odd vague vessel that crosses the posterior pole of the eye. And you can clearly see that. So that choroidal measurement may be altered or biased by that vessel. So it's hard to tell. I don't really look at it closely in daily clinical practice now.
Okay, maybe we can pass on other cases. This is another type of complication. It's neovascular complication. This is a man, 50 years. He came to me a week ago, and he had on the left eye, there's an error in the slide. On the left eye, he came with a small hemorrhage in the parafoveal region, and the vision was fair good on both eyes. So we performed an OCT. You can OCT. Can you describe the OCT and tell me what you think? It's a clear, simple case, but I think it's important to speak about it.
Yeah, I agree. It's a simple case. I think we would all agree we have a myopic CMV here that is clearly visible in this slide, with a very interesting sign that is this hyperreflective material that's associated to the activity of the CMV lesion. So based on the OCT alone, I think we can make a clear diagnosis. And regarding the questions you set on the slide, I do not usually perform fluorescein angiography or ICG. Well, I don't really have ICG in my hospital, but I didn't do it before, and I don't do fluorescein angiography. Generally, I think OCT with the combination with OCTA right now is usually more than enough.
Okay. Aude, do you agree with that?
Yes, I usually I think OCTA is a good tool to confirm, but even if you don't have OCTA, B-scan OCT together with the presence of the hemorrhage on the color-phonous photograph is enough to confirm the diagnosis. It's important to mention that contrary to IMD, it's not frequent to have a large amount of subretinal fluid or intraretinal fluid, as we can see in IMD, but this hyperreflective subretinal material is much more frequent. And as it's a type 2 neovessel, it's easy to see it on OCTA. It's the neovascular membrane.
We can see the OCTA of this patient, and we will see your cases after that. You will speak about the specification of. So what do you think about this OCTA? Do we have to look at the scans, or is it enough with just this image? What do you think?
Well, I think we can clearly see on this avascular slab the presence of the neovascular membrane. I like also to look at the B-scan OCT together with the flow overlay, so you can confirm that the lesion you can see on the end face is clearly the same, so it's the same, the similar location has this lesion here, and you can see the flow on the B-scan located in the region of the Neovessels. So it's really clear for the diagnosis, and it confirms the suspicion of Neovessel here.
Okay, Jorge, do you agree with that? I think it wasn't so clear, so I had to really look carefully of the SADA signal, because sometimes I think the signal in the intern retina is reflecting on the slab, and it's quite sometimes difficult to see if it's only a reflection of the internal vessels, of it's really the neovessels that are seen on the slab. So in this one, it's more clear than in the first one, and maybe in the other one, I don't know if we can see. There is still another one, a third one, maybe after that.
Yeah.
Yes, this one. On this one, it was very clear because above on the internal retina, you can't see any SADA signal, and you can see the signal only in the neovessel. So it was just to specify for maybe people who are not really aware with OCTA that it's sometimes difficult to see, and you must see the scans more than the 2D image. Sometimes it's confusing. So, and in my opinion, maybe you don't agree with that.
I completely agree. These tests, especially in highly myopic patients, are very prone to showing a certain degree of artifacts. So I think the best thing you can do is take a look at all the tests you get with modern devices. You get the fundus picture, the B scan, the 2D image of the OCTA, and the flow image. And with all the images together, I think in the vast majority of cases, you can get a very clear picture of what you're dealing with. The diagnosis becomes usually very clear. That, together with the fact that highly myopic patients are very reliable regarding the symptoms they're describing, makes the diagnosis and the indication of treatment clear in most cases.
Yeah. Of course, EF is sometimes necessary, especially to look for recurrence of the neovessels. And I personally perform angiographies when I have a doubt in recurrence of a neovessel that I can't see on RCT, because sometimes it's difficult to see the diffusion when patients have already been treated with anti-VEGF. So that's maybe the main indication for an angiography. But the first time, as in this case, it's not necessary for me. Did you try new anti-VEGF therapy to treat patients with neovessel, and is it recommended now?
Well, that would be off-label. I would not. Well, I have to admit I have tried both of those two new drugs. It's logical to think that if Eylea 2 does a good work with these cases, Eylea 8 should too, and the same thing happens with faricimab. You get the odd more active or more aggressive case where I have tried them and with good results. There's the faricimab trial ongoing regarding myopic CMVs, and from what I've heard, the results look good as expected. Really, those lesions have always responded well to anti-VEGF treatments, so we could not expect otherwise.
Thank you. We can pass maybe to your cases now.
Yes, just added these 4 cases to highlight the progression rate of atrophy when a CMV is involved. You have 4 different cases at the moment of the diagnosis of a myopic CMV, and every highly myopic patient with a posterior staphyloma is going to show some tendency or some trend towards a progression of atrophy. But when the myopic CMV appears, the progression of atrophy is so much more aggressive and can compromise visual acuity in the midterm. I wouldn't say long term even. So I just wanted to bring this up, so maybe we can discuss about that. But I think the atrophy related to CMV is maybe the main factor leading to vision loss in myopic CMV cases.
Yeah, of course. Yeah. And maybe, Aude, you can show us a few cases that you prepared too. And I think we will discuss about the atrophy and that is led by neovascularization.
Can we give control of the slides to Dr. Couturier, please?
It's the same slides. We can pass on. Or maybe. Normally, yes. We have to go on and directly on the, yes, this is.
Yes, so here it's a quite typical case of myopic new vessel with this really clear subretinal hyperreflective material. Here there is also a small amount of subretinal fluids that also, of course, is less frequent than IMD, but can also happen. This has been also confirmed by FA in this case.
So sometimes you make some effects.
Yes, yes, yes. I think there is no problem to do, but I need to say that when we can see well the new vessel on the OCTA, for example, in this case, probably angiography is not necessary. So here also is to show how the new vessel change after the treatment. So we also can see often patients with myopia having this inactive new vessels, and it's really important to differentiate so the active exudative new vessels that need treatment, while the inactive new vessel usually led this hyperreflectivity, subretinal hyperreflectivity, but which is really well limited without any subretinal hyperreflective material. Here, the edge is very clear and well delineated. So in that case, usually I go for a follow-up with a PRN because we know that we don't need so many injections as in IMD.
Yeah, I think it's important to note that the treatment and the way we do retreatments are very different from AMD.
Exactly. So this is just another case. Maybe, yeah, so here we can also have the image on OCTA. I can move, maybe this is also another case at the age of atrophic lesions. So sometimes a new vessel can also develop, so either on lacquer cracks or also at the border of area of atrophy, like in this case. You can see.
This is interesting to get back to the topic of Jorge, that atrophy is really associated with neovessel, but in both sides. I mean, atrophy can lead to neovessels and neovessel can lead to atrophies. This is a big landmark on myopic neovessels.
Yes, absolutely. We know that the majority of the patients having new vessel will develop atrophy in the area of the new vessel over time. But also eyes with patchy atrophy or even also a scar from a peak lesion could have this new vessel at the border, at the junction, in the junctional zone. Here is another case which is a differential diagnosis of a new vessel. You have a subretinal hemorrhage due to a Bruch membrane rupture, like a crack, and it's not always easy to differentiate from new vessel. It can be symptomatic because of the hemorrhage. Here you can see is almost subfoveal, and so it can lead to scotoma or even sometimes metamorphopsia. But here you can see that there is no diffusion on FA. In this case, we don't have OCTA, but probably so the OCTA will show no neovascular membrane. And the late phase of the ICG or also infrared images or autofluorescent images are important to confirm the lacquer crack. So you can see the linear is Bruch membrane rupture and the hemorrhage in the same area. So this is a differential diagnosis to have in mind when we have a macular hemorrhage here. I hope you agree, David.
Of course.
And here is the follow-up of the patient. So you can see the spontaneous resorption of the subretinal hemorrhage without any neovascular lesion in this area. And lastly, so this is a case of highly myopic eyes with some peak lesion. If we look at the OCT, you can see here the inactive lesion that are quite typical of this multifocal choroiditis or punctate inner choroiditis, with this really small area of interruption of the outer retinal layers and RPE, with a collapse of the outer retinal layer and the hypertransmission in the same in this area. And it can occur also in a linear location, and it could be colocalized with also lacquer cracks. So this is also important in these cases to look to have some follow-up and look at any active lesion in the future that should need some treatment. Not only anti-VEGF if there is a new vessel, but also anti-inflammatory treatments. I think this was my last cases. I don't know if you want to comment, David, on this kind of lesion, if you are doing specific follow-up or treatment. Here, the cases don't seem to have any active lesion for the moment, but some close follow-up is follow-up of the lesion
not
is
really.
needed.
Jorge, do you have a specific follow-up for patient with probable inflammatory neovessels in high myopia?
Yeah, I think well, when you have an active episode, you obviously have to follow them up very closely at the beginning, and of course introduce that anti-inflammatory treatment that can really change the prognosis of these patients. But once they're stable, the follow-up is not that different to the regular highly myopic patient, and you always trust these patients that they'll come with symptoms whenever they have an episode. So once they're inactive, the follow-up's not that different to me.
Okay. Thank you very much for commenting all these cases. I think it's interesting, and we will have hopefully some questions at the end of the session. But I will pass the presentation to the Dr. Matteo Mario Carla and Dr. Elise Philippakis. They will speak about the management of surgical complications, the maculopathy in high myopia. Thank you very much, both of you, top surgeons, and you will talk about how to deal with these complicated patients.
Thank you, David. So we'll now talk about surgery with Matteo, and we are very happy to present a few cases so we can discuss practical cases. So I will ask Matteo first. In this young patient, as you can see, has probably a myopic traction maculopathy. She has it on both eyes. The vision has dropped, and especially the near vision. So maybe, Matteo, you can, for teaching purposes, you can elaborate a bit on the semiology and why would you go or not for a surgery here?
So thank you, Elise, and thank you, David, for the kind invitation. Well, in this case, as we all know, that the first hint to follow up for surgery for a myopic patient is surely the near vision. And in this case, with a young person with bilateral myopic phobioschisis, which has effectively which had a loss of visual acuity, we have to look at some semiologic important aspects on the OCT. In this case, we can see particularly there's an outer retinal lamella hole with a small foveolar detachment, which is really important, that it has been demonstrated with the choroidal hypertransmission sign as a bad prognostic sign in terms of evolution. So the most important things in myopic foveoschisis is the possibility for the foveoschisis itself to keep stable over time or to worsen over time. In this case, I think that the association between an important traction, which may have been worsened over time, and in particular, the foveolar detachment and the outer lamellar hole may be a clear indication for surgery. What do you think, Elise?
Yes, I completely agree with you, and especially in this case, as there is a high risk of progression towards a macular hole, I would advise the patient to have surgery quite soon. And because she's young and phakic, we'll try to have a surgery that is less invasive and maybe adjust the technique. So, what kind of ILM peeling technique would you do here?
In this case, particularly for the specification of the case, as you can see, the really small roof we have at the apex, I would suggest to peel the membrane, but to make a foveal sparing technique in order to minimize the risk of iatrogenic trauma and minimize the risk to end up with a full thickness macular hole.
Yes, as you know, there are a lot of papers suggesting that the fovea sparing technique has allowed to drop the rate of postoperative macular hole, and therefore allows us to avoid the use of tamponade because you don't have a hole, so you don't need to put any gas, and that changes a lot of things, especially on young patients and also in monophthalmos patients. So maybe we can look at how to do this ILM flap. The idea is to peel the ILM not too close to the fovea and then to bring the flap towards the fovea. There's no need to take it onto the edge, especially in this technique, because you don't want to do an ILM flap like in macular holes. You can just leave some of the ILM on top of the fovea, but it needs to be trimmed not to have a little mustache of ILM.
And what about this case, Elise? Even a male, young male with, in this case, monolateral visual loss, but in this case, there's no outer retinal hole. How would you deal with this?
In this case, I think it's probably a borderline case for indication. What the things we can see is that the patient has a narrow macular staphyloma, which is especially exposed to develop this kind of myopic traction maculopathy, and therefore you will probably get a progression. But here in this case, as you can observe, there is an outer retinal schisis, but there are not outer retinal layers alteration. So that's why the vision is quite conserved. But in these cases, you don't have a risk for a macular hole, even if you peel completely the ILM. So here I would go for a membrane and peel the ILM and just leave it if I don't have any other peripheral complication, because as we can observe on the fundus picture, we do have some lattice degeneration, some laser. So maybe the periphery will not be as kind as expected or wish. So I will go just for a peeling here. Do you agree?
And yes, I kindly agree. But in the literature, there were also some kind of reports which demonstrated that in this kind of simple foveoschisis, the only hyaloid peeling would be also enough in this case, just to preserve the integrity of the macula. What do you think about that?
Yes, I do agree that sometimes just a vitrectomy is enough and you don't have to peel the ILM. And that has been also reinforced by our paper on the spontaneous resolution of the schisis. And in young patients that have this kind of vision, a borderline indication, we can look at the vitreous attachments, if there are a lot, if the vitreous is still attached. And sometimes just seeing the vitreous is challenging, because lifting the vitreous or waiting for the posterior vitreous detachment to occur can prevent doing an unnecessary surgery. So that's a very good point. So if we move to macular holes, here, Matteo, we have this case. She's 60 years old. She was followed up actually for a Neovessel on the right eye, and the left eye had this kind of lamellar hole, and now has a Neovessel. So when you have a Neovessel and a lamellar hole or macular hole, what do you deal with first?
In this case, I would deal first with the neovascular complication, since the neovascular complication itself may attract the retina, may exert a traction, a centrifugal traction on the retina, and only the reduction of the subretinal fluid, the subretinal neovascularization, may also favorize the closure of the macular hole. So at first, I would move for an injection. Looking after, probably it was not enough.
Yes, indeed, but I completely agree with you, because as we know, complications are not exclusive one to another. So if we have a Neovessel or if we have a doubt, we should treat the Neovessel. But after one injection, here you do have an opening of the hole, but a few cysts and the Neovessels. But I don't know what you think. Would you believe that the cysts are still some kind of exudation or not?
In this case, I think that the cysts, particularly for the position being also on the nasal side, are more related to the hydration of the hole, since coming back from the lamellar to a full thickness macular hole. So in this case, I really do not think that another injection would be enough. We can talk about the possibility to make observation with medical treatment, in this case of a small macular hole, which has been demonstrated as effective in hemetropic patient in a small percentage of case, but with strict follow-up, I would suggest, before going up for surgery also in this case.
Yes, because if you look at the OCT, you can see that there is some epiretinal proliferation. So the problem is, if you wait too long, you will probably have some progression of the hole, and the vision is still good. And as we know also in hemetropic eyes, the earlier you operate on holes, the best visual rehabilitation you have. So this is a tricky situation. You could expect some closure, but there was not some kind of traction. So in these cases, the spontaneous closure rate is not as high as we can hope in hemetropic. So I would not delay the surgery too much.
And on the other hand, do you think that exerting a peeling on a membrane which has been active since some months before would be a stimulus, a trigger for a reactivation in this case?
In these cases, I would inject during the surgery, because I would like to make sure that I have full control on the Neovessel, so I don't have any other traction on the retina, and to make sure that the hole closes. But we cannot completely prevent the reopening of the hole if we have a Neovessel that it becomes active in the months following the surgery. But let's hope for this patient that we operated. So just to be a bit clear about the indications, we have here 6 cases. And so let's say what we should do on these cases. So on the first one, we have this outer retinal opening. We have the fovea detachment, but there is no opening of the inner retinal layers, and we have the vitreous attached. So what would you do, just in 2 words?
Well, in 2 words, in this case, hyaloid detachment and surely ELM peeling also peeling the fovea with no risk in this case in particular.
Yes, I would do a fovea sparing here and no use of tamponade.
I'm sorry to interrupt. Well, can I ask a question? Well,
yes.
In this case, well, the macular detachment is huge. Do you care about vision, or do you indicate the intervention even if the vision is fairly good? Let's say 4 on 10, 5 on 10. I doubt it because I think the situation is quite serious. But I mean, in that particular case, when the macular detachment is important, you don't really care about vision, or is it still an important factor to take in consideration when you operate?
You always take care in consideration the vision, but here I would go for surgery maybe sooner than later, because if you have an opening of the inner retinal layers, then you will have a huge macular hole, and it will be probably more difficult to close and with a worse visual prognosis than if you peel the fovea sparing. So this kind of huge detachment will more urge me to surgery, regardless of if there is a still good vision. But in clinical experience, I'm sure that you will guess that the patient did not have a good good vision here,
good
especially
vision. No, it was just a question, but I would do the same. I know. I would do the same. I would operate. Yeah.
But sure. Here, Matteo, what do you think? We have these large macular detachments, but the inner retinal layers seem more difficult to define. Here, what do you think you should do about tamponade, for example?
Here, in this case, I would go for a tamponade, and then building up of previous studies. In this case of macular detachment, also making a flap may enhance the result, since standard ilm peeling technique has a lower percentage of success in these particular cases of macular detachment, retinal detachment associated to full thickness macular hole.
Yes, because here it's not very clear if we have a complete hole, because it's so stretched that the OCT sometimes cannot see. But since we have this large detachment, we probably have a hole there.
This clear choroidal hypertransmission may be also a sign of full thickness defect in these particular cases.
Yes. And so here in the two cases, can you tell if you will put tamponade or not? Here on
in this one, not specifically. The roof of the retina is well extended and will be closed progressively without problems.
And on the other one, you have some defect.
Yes, in this case, I would go for a gas tamponade on the other hand.
Okay, and here with the lamellar hole, what kind of peel with full thickness macular hole? What kind of peeling would you do? Complete peeling or ILM flap?
Well, in this case, I would go for a flap, but the undermined edge of the hole are not a good prognostic sign. So it's a hole which risk to reopen and to go for further surgery for recurrent macular hole.
Okay, and would you go for I don't know, amniotic membrane in first indication here?
Well, if we still have an ILM, I would first peel the ILM, making a flap. Keeping the amniotic membrane as a second surgery, or retinal flap or autologous retinal flap as second surgery. And what do you think about that?
Yes, I do agree that if we have ILM, we should use it, and use it in first indication, especially in myopic eyes, because it has helped to improve the closure rate in these eyes. And I will keep the last case for me, because in this case, you can see there is a lamellar hole, and some proliferation on top, but there is no threatening of macular hole. But in this case, especially, the fovea sparing technique does not work well. In these cases, we should peel the proliferation to the edge, like in ILM flap, but just for the proliferation, and then peel the ILM and put some tamponade, maybe not a very long active gas, but at least some air in these cases. And on that topic, Matteo, how do you manage the gas tamponade in myopic patient? Do you use longer acting gas, or in contrary, do you use shorter acting gas?
In these cases, in particular for macular complication, I always prefer short-acting gases, since I think that the dehydration of the hole really happens as in hemetropic, as in myopic eyes, in the 24-48 hours after surgery. So the closure, the success of the surgery in case of macular holes is well gained in the 2-3 days postoperatively. In cases of flap or well-positioned flap, myopic macular hole, as we described, may have a delayed closure, but the flap itself is able to get to keep the dehydration of the hole, which is the main trigger for the closure. So I would not see the point for a longer acting gases, knowing also the complication or the visual loss associated with longer acting gas, particularly in myopic patients.
Yes, indeed. The myopic eyes keep the gas longer than hemetropic. So if you put C3F8, they are gone for 3 months of gas, and sometimes a bit long, especially in monophthalmos eyes. So we have still a little time to discuss 2 complicated cases. So this patient was monophthalmos. She had a poor vision, but experienced some vision loss. And as we can see, we have some schisis, some macular hole full thickness, and we can observe that there is a proliferation on the edges. So there was a lamellar hole at the beginning, and it's very difficult. She was strictly monophthalmos, had a prosthesis on the other eye, and did not want to have surgery. So I had really to convince her, and she was alone at home. That are things that need to be discussed with patients during consultation if you decide for surgery in monophthalmos myopic eyes. And then after 2 months, I saw her just before the surgery, and it's very interesting how the edges of the retina has flattened. The schisis has disappeared because of the retinal opening, and the base of the hole has worsened. And here I have a video afterwards. They have this proliferation will present as a surgical difficulty because it's very hard to see it and to peel it. So I did the surgery, and I'm showing you how I think I did not. I did the peeling, and then I had very difficulties to see. I don't know. I think I did not capture it well. Sorry. But as you can see, you have to peel and then keep the proliferation on the center and peel away the ILM, and then do the exchange and trim. So I will move on because I want to show also your cases. But the surgery was a success, but the visual recovery is not always as good as we'd hope. And so I will let you present these cases that we saw together.
Yes, this is a recent case we operated with a 77-year-old male pseudophakic, which has experienced a visual loss in his left eye, knowing that his right eye was already in atrophy, had already macular atrophy. In this case, he had a great schisis, a foveoschisis with a great traction of one of the edges, and the risk of developing a full thickness macular hole was still there. The problem was that the patient, in this case, had an important damage at the level of the its visual field. And this is his photo. So knowing the risk of worsening of the vision, we got to the surgery. The patient was operated, we made ELM peeling and gas tamponade. And 1 month after, he came last week in consultation. The anatomical result was fairly good, but the patient experienced subjective aggravation, telling us that the other eye has become the better one, which was not before surgery. So I'll ask you, what do you think? Which is the risk of operating patient with this level of visual field alteration? Do we have a point for gas? In particular, in this case, just as a point, we used gas since we found a small detachment outside the staphyloma area, and we prefer to go for gas instead of leaving the patient underwater.
Yes, I think this case really highlights the importance of doing visual fields in schisis cases, especially when you have a doubt on the optic disc. Moreover, if they are monophthalmos, and sometimes visual fields like that makes you reconsider the surgical indication. Here in that case, the patient was quite pushy towards surgery and really worsened. But when you have this kind of visual field, you should take all the aspects of the surgery in consideration. For example, the general anesthesia that make lower perfusion of the optic disc. So you have to be careful about the pressure around surgery, a really good control of the pressure. And of course, the anatomic outcome is good, but it's a bit early to assess the final vision. So maybe we should not drop to conclusions too quickly about some toxicity. But of course, if we could have avoided gas here, it would be better. But also be careful about the suture of the sclerotomies here and the pressure of the eye after surgery to avoid any other complications about pressure in the perioperative timing. So I think we're done for our cases, unless, David, you have a few questions. And,
thank you very much. Yes, I have a few questions, and we have a few questions on Q&A. So if there is some ultimate question, we've got 2 minutes for Q&A. Some people ask about what's the aim of ELM tamponade above the hole? How can it help to close the hole? Have you a good answer for that?
When you do an ILM flap, the idea is to put some support and some barrier between the vitreous cavity and the subretinal area, which is what is needed for the hole to close for the liquid reabsorption. So when you do an ILM flap, you will enhance this process, and especially as Matteo has published in a recent paper, the gas in myopic eyes will not completely tamponate the retina as well as in a metropic, because the staphyloma makes it harder, and it depends on the type of staphyloma. Is that right, Matteo?
Yes, that's right. That's what we found in a large series of patients operated, that the morphology of the staphyloma may influence also the visual acuity and the results, since we all know that there are several types of possible macular hole closure, and sometimes we know that the flap which we use is undermined. It does prevent the retina to slide in order for the external layer to reconstitute. And this may happen in cases of peripapillary staphyloma, for example, in which there is an uneven contact between the gas bubble and the retina for this case, underlining the importance of having a really stable flap with a lot of techniques like visco-assisted surgery in particular cases, for example.
Do you use sometimes silicone oil or amniotic membranes, and what are your indications for those particular type of surgery in highly myopic eyes?
In particular for silicone oil, at first I cannot see the need for using a silicone oil in cases of simple macular hole, but also in cases of macular hole retinal detachment, unless other breaks at the peripheral retina. On the other hand, the amniotic membrane has been demonstrated to be really efficient in order to close big and large macular holes above 800 microns. I would leave it as a second intention, and either the epiretinal, either the subretinal technique for the amniotic membrane may be effective. The problem in this case is in recurrent macular hole in myopic eyes is always the visual acuity at the end. Since we found improvement of visual acuity in hemetropic eyes, in highly myopic eyes with large chronic macular hole, it still have controversies.
Yeah. I would just complete that silicone oil is worse to tamponade than gas, and thinking that putting silicone oil in monophthalmos patient is a good idea, I would really advocate for using gas tamponade to avoid another surgery to remove the oil. And as you have studied and published, David, we cannot prevent completely silicone oil toxicity and after silicone oil removal maculopathy. So in these eyes, if you can avoid complications from your surgery, it's better. No hole, no tamponade, and if you have to use tamponade, use gas instead of silicone. I think it's good to give strong ideas, and then you can always reconsider it in very complicated
You're right.
cases.
You're absolutely right. We're running out of time. I think we answered all the questions that was asked in the chat. So thank you very much, the four of you, to have participated to this webinar. I think we answered a lot of questions. Thank you for your beautiful case, and well, I hope we will see each other soon for maybe another webinar or on the Congress. Thank you and good night.
Thank you, David. Good night.
Thank you, David.
Good night.
Have a good night.